eye is left. And then you express the lid, pull the lid away, slightly touch on the inferior lid margin so that the dye is just transferred onto the eye. And then you ask the patient to blink few times, and then you go and assess how the tear is breaking up. Sometimes it's better. As of now, few of my cases, I'm now using a yellow filter also. So that enhances the display. Now I'm seeing many things which I was not seeing earlier. I had few patients were complaining, but the stain would look normal in the normal blue light. Once I put the yellow filter, I start seeing more PEs than which I used to see, even the conjunctival ones. So that would be the simplest ways to do it.
Exactly. So you have to create a hanging drop and then touch the, no, do not touch the ocular surface and do not use any things like paracaine and all. And Anil can, I think, enlighten us more to the selection of a lubricant. That will be, you have touched upon trehalose based lubricants and also the osmoprotectants. So in what dry eye, like you select osmoprotectant, or is your trehalose containing lubricant you are and also the hyaluronidase are you using as a first line treatment?
I think it's a extremely difficult question to answer. I think there are two components. One is the part that as clinicians and as people who are researching on dry eye for so many years, people have not really found out exactly what is dry eye. That is the truth. I think during my post-graduation, the only lubricant that was available was Moisol. I think we have made a small progress, maybe 5 to 10% progress, nothing really beyond that. There are a lot of talks on inflammation as a cause for dry eye. Yes, it is definitely there. About 65 to 70% benefit from it, and inflammatory therapy has its role. Has its role, but generally speaking, the more common type of dry eye that we see is the short tear breakup time. It can be either because of a lipid abnormality or because of a mucin abnormality. Mucin abnormality is something that is very commonly seen in especially computer visual display terminal users. So that is it's not really the inflammation sort of dry eye. In such people, if you can use something which is mucomimetic, that would be much better.
Just to, answer that question on which lubricant, how long, when to change, when to add some other, agent to it. I think I think it is best to keep it simple. So first you start with your CMC or your HPMC kind of agents. If they don't work, especially for the mild dry eye, if they don't work, for instance, the moderate ones, then you go in for polyethylene glycols or the PEG component. I'm saying pharmacological names because generally what happens is that the companies and all, they tell you use this, use that, and we really don't go into what is the pharmacological name. And if it still doesn't work for moderate dry eye, then you can use sodium hyaluronate. And then this is the third category, and the fourth would be that you use a combination. So when you use a combination, you'll use like sodium hyaluronate and CMC, or you'll use sodium hyaluronate and PEG. So that goes in for your moderate to severe dry eye. Very severe dry eye, sometimes you may have to resort to, tarsorrhaphy or to punctal occlusion and your other kind of things. Of course, where do these immunosuppressants come in? I think they come in whenever there's a component of inflammation. Then you have to give immunosuppressants, which could be cyclosporin, which could be liftigrast. And cyclosporin now has come in various concentrations and various formulations. And I always like to use topical steroids to break that vicious cycle in between. Because if it's really inflamed and dry, and how do you know it's inflamed and dry? It is red. So you have to get it to the point where that red becomes white. And when you have a white eye or an uninflamed eye, then you know that there's no inflammation. And you can continue with your lubricants as you do. Of course, whenever your frequency increases more than 4 times a day, then you go in for preservative-free formulations, because you don't want preservatives to be there, because they again would have their toxicity effects.
That was exactly what we wanted, ma'am. Thanks for that. And is it? So we have the much awaited talk of our eminent speaker, Dr. none other than Dr. Namrata Sharma from RP Center. So she'll be talking to us about a paradigm shift in the management of dry eye. Because so many drugs are coming up, and we all know that there is some ocular residence time, ocular surface residence time, because 70% of all the drops is lost due to blinking or some other reason. And all the companies are trying out to increase the residence time. So different techniques are into use, like
thank you.
increasing the strength of the drops and all.
Thank
Over
you,
to you, ma'am.
Thank you, Anita. And it's always a pleasure to come to Kerala. And always I say this whenever I'm on a platform in Kerala. And the best scene to see is, you know, so many female ophthalmologists, almost 95%, with due regards to all the men here. But that's the pleasure to see, which I don't see in any state. So lovely to be here again. And I'm so happy that all of us are now taking ophthalmology. At our times, only 5% were ophthalmologists, females, and 95% were male ophthalmologists. But it's lovely to see here. So I would be talking to you about paradigm shift in management of inflammatory dry eye disease. And it is a multifactorial disease. I think you must have, this must have been already covered, but it is a multifactorial disease because it's not a single symptom, it's not a single sign. It is something which was recognized from 2007. Earlier it just was passed off as dry eye. Then it is something which actually encompasses the entire spectrum, right from eyelids, lashes, tear film, main and accessory lacrimal glands, and the meibomian glands. And there is loss of homeostasis, which goes through the central pathophysiological concept, again something which was not known. Symptoms are very important because they never corroborate with the signs that are there, and there can be many etiologies which we really need to know. And of course, I think the most important thing is that you need to know when you are treating a patient of dry eyes whether the inflammatory component is there or not. Now, this is a busy slide which just goes on to say that this is a vicious cycle of inflammation, dry eye disease, and MGD. And when it is a vicious cycle, you have to break it somewhere, be it steroids, it doesn't matter, or be it immunosuppressants. So when you break it at a particular point, with the use of topical steroids or immunosuppressants, then you can continue with lubricants. Lubricants are something which the patient, you can never take them off once you start the patient on dry eye. Of course, investigations, I think Madhu very nicely covered the investigations. And there are various signs which need to be treated, like conjunctival hyperemia, conjunctival staining, because with the lissamine green, which will tell you the extent of inflammation. Then the lid parallel conjunctival folds. Confocal microscopy may not be available everywhere. Tear osmolarity, I think, is important, but I think it is more an effect rather than the cause of the dry eye. And I also feel, I did go through the first half, but I feel that it is slightly overrated. But then, of course, if it becomes normal, then it helps you to know that, you know, your treatment is working. MMP9, which again is not very specific because it has to go really high to be detected and to be saying that there's some inflammation which is present. So there are triaging questions, the risk factor analysis, the diagnostic tests, and the subtype classification, because based on the classification you are going to treat. So if it is a mild dry eye, it is only patient education, modification of the local environment, and ocular lubricants. Like I told you, and initially I would start ocular lubricants 4 times a day, which would be something like a CMC. Then step 2, if it is more than 4 times a day, we start with non-preservative lubricants. Demodex will be treated with tea tree oil. Tear conservation is very important with punctal occlusion if required. And of course, the drugs have to be prescribed. And if there is inflammation, then topical steroids can be given 4 times a day in frequency. I don't like to give, although this is a Sun Pharma session, but I don't like to give Lotepred or FML for that matter. If I have to give steroids, I'll give a full-on steroids because we want to break that vicious cycle. So it will be something like prednisolone acetate, which will be 4 times a day. Then topical non-steroidal immunomodulators, cyclosporin has a role to play. Liftigrast is undergoing trials, is available as Xiidra in US, but is still not available with us, and oral macrolide or tetracycline wherever indicated. Now, if it is very severe and the patient is really uncomfortable, you can give oral secretagogues, which could be pilocarpine, which is given 3 times a day. But again, the systemic side effects are quite a bit. Then autologous or allogenic serum eye drops can be given, and these are helpful, 20% in concentration. And of course, if the above options are inadequate, then you have to give topical steroids for longer duration, amniotic membrane transplants, tarsorrhaphy, and even minor salivary gland transplantation. Now, what are the challenges? We have definite ground why immunomodulators should be started, but there are certain challenges which are there, and these include the following. Now, there have been studies in more than 7,000 patients which had patients of topical cyclosporin also, and majority of the patients actually discontinued topical cyclosporin, close to 60%, close to 70%, and close to 60% discontinued liftigrast. So discontinuation does occur in these patients, and this occurs mainly because of burning and stinging and lag time which is there between the treatment initiation and experiencing the symptomatic relief. So this may lead to disease progression, especially when the patient discontinues, and so you do require a maintenance therapy. Now currently we have liftigrast, but the liftigrast also causes other side effects like dysgeusia and reduced visual acuity or blurring in some of the cases, apart from eye discharge, eye discomfort, hyperemia, sinusitis, etc. Topical cyclosporin 0.05%, which is currently available, does cause ocular burning in almost 17% of the cases, apart from conjunctival hyperemia, discharge, pain, foreign body sensation, stinging, etc. And the effect of the topical cyclosporin 0.05%, which is currently available, starts within 6 weeks. So the unmet need is that the currently available cyclosporin is actually available to you in oil and aqueous solution, and the solution with the drug particles do get suspended in oil particles, but it tends to be unstable with poor ocular tolerability, hampers the dissolution and penetration into aqueous tissue, and it must be shaken to resuspend the drug particles. Again, it will cause blurred vision and low bioavailability in ocular tissues, which will impact on the onset of action, which I said was 6 weeks. Now, cyclosporin 0.09% is the ophthalmic solution, which is made by the nano micellar cell technology, which basically has a hydrophobic shell. So this allows transport through the tear film onto the ocular surface and has a hydrophobic core, which prevents the encapsulated cyclosporin from being released until after the penetration into the aqueous layer. So because of this, the penetration is also faster and it acts faster. Now, again, this is to show the same, that this N cell encapsulates and this hydrophilic shell which is there, it gets dissolved. So with the N cell technology, the cyclosporin penetrates inside and then it gets delivered onto the ocular surface as well as intraocularly. Now, this was a study which was done in animal eyes, the New Zealand rabbit eyes, and just to show that if you look at the concentration of 0.05% Restasis versus 0.05% micellar cyclosporin and versus 0.1% micellar cyclosporin, then you can see that the 0.1% micellar cyclosporin in conjunctiva and cornea has higher concentration, and again in all the tissues in fact has higher concentration. So it has gone through 3 phases, phase 2B, 3 clinical trials, phase 3 clinical trials, and the long-term safety extension study. And if we